it's my pleasure to introduce the first speaker, Dr. Christine Eng. Dr. Eng is a professor in the Department of Molecular and Human Genetics at Baylor College of Medicine. She is the director of the Storage Disorders Clinic at Baylor. In addition, she functions as medical director and director of the DNA Diagnostic Laboratory, and also as director of their new whole exome laboratory, where whole exome sequencing is offered as a clinical test. Today, Dr. Eng will speak to us about clinical whole exome sequencing, outcomes, and indications for testing.
Thank you very much, Ginny. Pleasure to be here today in such a nice setting as Asheville, North Carolina. Also, I would like to add my words of condolences for the 4 members of SERGG that have recently passed, and they will be missed. As Jennifer mentioned this morning, I'm going to talk to you about our whole exome sequencing program at Baylor, which started about a year and a half ago or so. And so I'll give you an update of the program's progress, also talk a bit about some of the logistics of the program as well. And I guess we're going to have questions at the end, or? Okay, sounds good. And somebody's going to have to keep me on time. So, so I don't really think I need to go into this in too much detail for this audience. I think we all know that making diagnoses for genetic patients can be challenging. And that's for many different reasons. There are thousands of genetic disorders, and most of them are quite rare. There's some common ones. There's some ones that we consider common or at least easily recognizable, such as Hunter syndrome, but that's still about 1 in 150,000. Also, the challenge is the genetic heterogeneity. And as we're learning more about certain genes and their relation to clinical disease, we're understanding even to a greater extent the clinical heterogeneity of many of these conditions. Often there is very specialized testing that is needed to confirm the diagnosis, and that is usually best done by medical geneticists. And as we all know, we are fairly a rare group, even amongst ourselves. And, there are about 3.5 geneticists per 1 million population. So in genetics clinic, and I can tell you from my own patient population, it's at least 50%, if not maybe higher than that, of patients without a confirmed diagnosis. So if you look at the diagnostic yield of some of the tools that we have had in genetics, karyotype has a diagnostic positive yield of about 5 to 15% if you look at different studies. Array CGH, which is relatively new, also has about a positive rate of approximately 15 to 20%. Again, if you look at different series, you may get somewhat different numbers. You can contrast that with single gene testing, so single gene Sanger sequencing testing. The pickup rate really varies depending on how specific the phenotype is. So this is when you're ordering a specific Sanger test for a specific condition that's on your differential diagnosis. If you look over at the far left here, so this is FOXG1, this is congenital variant of Rett syndrome. From our DNA diagnostic lab at Baylor, for the number of samples that we had submitted over the past 5 years, the positive rate was less than 5%, 2 to 3%. As you travel along, you see that the numbers get slightly larger. Again, these conditions here are relatively nonspecific, perhaps intellectual disability, dysmorphic feature syndromes. But as you get to CHD7 for Charge syndrome, the pickup rate is higher because the recognizable presentation is more easily assessed. Interestingly, also for MECP2, our pickup rate in the lab is, again, less than 10%, that's 7 to 8%. So I think panels might be a bit different, but I think we'll be hearing the next speaker talking about the pickup rate for panels. That is, in our experience, also very panel specific. Our bone panel, for instance, has a very high positive rate, but other panels, such as intellectual disability, will have a lower pickup rate. So we know that exome and genome sequencing has been very productive in a research setting. So this is instances here from the Baylor group where the Genome Center has collaborated with clinicians with specific groups of patients with recognizable syndromes that have yet to be discovered. So I know this is difficult to see, but here this is a study that was published in 2011 about the CAT6B gene that causes genitopatellar syndrome. We also, subsequent to this paper, identified a patient with this syndrome through exome sequencing. And there are many other examples and many examples that are in the literature, every time a journal is published, of exome and genome approaches to gene discovery. In terms of the use of exome or genome analysis on a research basis, there were some early studies as well that sort of set the stage for perhaps the introduction of this technology in the clinical setting. This is the paper that that really helped Baylor to develop our program. This is Bill Gall's program at the NIH for the Undiagnosed Diseases Program. And I think probably if you haven't seen this paper, I really do encourage you to take a look at it. It's a program that was intramural at the time. There was an RFA that was out for sites to be set up around the country. And it's basically taking undiagnosed patients, subjecting them to both clinical exam, perhaps studies that are informed by that clinical exam, and then going on to other approaches, either exome or genome. And on the basis of that study, they came out with a 24% positive diagnostic rate. And again, that's by using a variety of modalities, both clinical, targeted testing, and then going on to exome or genome testing. There's another article by Delict from the New England Journal in 2012. This was a more specialized cohort of patients with severe intellectual disability. And I believe they had to have an IQ of less than 60. And their diagnostic rate through exomes was approximately 16%. So on the basis of this and other studies, we set out at Baylor to develop a program where whole exome sequencing could be used in a clinical setting. And I'll spend the rest of the talk describing our program and also our early findings. So in terms of the development of this program at Baylor was fairly unique in that two groups that are independent came together and contributed to their various areas of expertise. So we have the Human Genome Sequencing Center led by Richard Gibbs with many, many years of experience of high throughput sequencing mostly on a research basis, with certainly the technical know-how, the bioinformatics know-how, collaborating with the Department of Molecular and Human Genetics. The Medical Genetics Laboratories is within this department and brings many years of experience of clinical testing, as well as cap and CLIA knowledge, as well as the clinical background. And so these two groups came together to form a lab called the Whole Genome Laboratory, and developed this workflow for the whole exome analysis. Many of these procedures were adapted from the Genome Center and put into a cap and CLIA environment. So there are QC steps at every stage of the technical process. Some of the more important QC metrics are that the data analysis has to be greater than 10 gigabytes. Greater than 95% of the target bases of the exome have to be covered at greater than 20x. Greater than 85% of the target bases are covered at greater than 40x. And the mean coverage that we'll accept as part of these QC metrics is about 140x or greater. We also do a SNP array internally as a control, so that we take the SNP calls and we correlate them with the sequencing calls. And we require greater than 99% concordance there. So this is just showing you that there is a consistency in this cap and CLIA whole exome laboratory. This is 12 batches, consecutive batches of clinical samples, and you can see this line here. There a high degree of consistency with greater than 97% of the target bases covered at 20x or greater. So also from these 12 batches, the total gigs per sample is about 13.5, and then the coverage here, the mean coverage was 168x. After the sequencing, it goes through an analysis pipeline. This again is a clinically adapted version of the bioinformatics pipeline that has been in use at the HGSC. The reads from the instruments are mapped to the reference sequence. Then the SNP as well as indel variant calls are made. All of this information gets funneled into a LIMS system. We also do the SNP array concordance, and then this final file is delivered for clinical interpretation. Because of the depth of coverage, we are receiving about 200,000 variant calls per sample. And so obviously this has to go through an annotation and filtering system in order to deliver variants that can then be interpreted clinically. So various steps of variant reduction are performed. First goes through a quality filter, then we look at HDMD. We sort out those mutations that have minor allele frequency of less than 5% in a public database. For those that are not HDMD, we look at whether they are predicted to have a change in splicing or the protein. We also look at minor allele frequency, but we have a much lower threshold there. And then finally, after all of these steps of variant annotation and filtering, there is a final output file of about 400 to 700 variants, which the clinical team then works with. So the different steps, again, are put in for variant interpretation. One of the most important is that we correlate it with the patient's phenotype. So our clinical test is very much focused on what the presentation of the patient is. In addition to the correlation with the patient phenotype, we again look through the patient public databases. We also have a growing internal knowledge base. We've completed over 1,000 samples thus far. And so so even when we get a hit, let's say from HDMD, we go into the literature, we confirm that, we further annotate that in our internal database. So as we get more samples, this internal database of curated information is enlarging. We also pay fairly close attention to a new gene and update a new gene list. So as I said, every time a journal is published, there are multiple new genes that are being identified that have relation to clinical disease, and so we keep a list of these, and then we look backwards to see if we had any positive findings in these genes before they were identified. And we've had a couple of examples where we've had to go and amend reports. So who performs the clinical reporting of the whole exome? There's a sign-out team of ABMG certified lab directors, medical directors, clinicians, and genetic counselors who all participate in this. We do a few different levels of independent review. Two of these independent reviews are PhD level individuals, and a third level of review is a clinical review, either by someone like myself or one of the genetic counselors. We report in two different formats, and I'll go over this, a focused and an expanded report. And what the components of the report are your sequencing result. We also do confirmation using another technique. At the moment, we're using Sanger sequencing. So anything that is of import that we feel is diagnostic that we're reporting, we have confirmed by Sanger sequencing. We've also request the parents, and we'll do Sanger sequencing on the parents. So we don't do trios per se, but we do Sanger sequencing for any important findings, not only to confirm the sequencing findings, but also to show whether the change is de novo or whether it's inherited, if it's autosomal recessive, if it's in trans, et cetera. We've also added the mitochondrial genome to this as well. This is done separately from the exome capture. It's by long-range PCR. A library is then made, and then it's sequenced also by next-gen techniques. And the coverage of the mitochondrial genome, because it's so small, it's crazy. It's like 30,000x. As I mentioned, we pay very close attention to the disease phenotype. We ask for this information in a couple of different ways. There's a requisition form here that I don't think you can see too well, but we ask you to fill out by organ system the findings. We also request a clinic note, and so this is where we find the most information because we're able to see almost in real time what the clinician is thinking, the differential diagnosis, what path they're going down, what they've eliminated. It's just very, very rich. And so we ask for a clinic note from every patient, and usually we do get that. So as I mentioned, we report in a couple of different tiers. The first is a focused report, and this is focused on the disease phenotype. So these are, this is the area where we report deleterious mutations in disease genes that are related to the clinical phenotype as it's been presented to us. Also, we will report variants of unknown clinical significance that are related to the phenotype. We'll report medically actionable mutations, so these are unrelated to the phenotype, but medically actionable, or another word is secondary findings, incidental findings. So we all know this is a very, very active area of a discussion at the moment. We'll report some very limited autosomal recessive carrier status genes, and so these are ACOG or ACMG recommended genes such as the Ashkenazi panel, sickle cell, CF, so forth, and some very limited pharmacogenetic loci. But the bottom two are areas that we think will be expanded in the next year or so. So this is a look at what the report looks like. So this is all the information that you would get about a particular change. We've added, so there's some comments here where we will say whether there's an article and give a PMID number if we use that to help with interpretation. We also are now giving the SIFT and polyphen, as well as some information about these public databases. The definition that we use for medically actionable, so as we all know, there's this ACMG recommended list, but before the list came out, our approach was that we would use a certain threshold for reporting. So the threshold was that the finding had to have direct clinical utility, either based on established guidelines or medical, from medical societies or in the medical literature. There had to be availability of treatment or established guidelines for disease prevention. So examples of this would be something like Marfan, NF1 or NF2, preventable or screenable disorders such as the hereditary cancer syndromes. We now have adopted the ACMG recommended list, but we are still using the thresholds for reporting that we had used previously. So we may report things that are not on the ACMG recommended list. In addition to the first tier, we have a second tier, an expanded report, and these are findings that are not related to the phenotype. So these may be adult onset conditions, things that are unrelated. Families may not want to know this, therefore they can opt out, or they actually have to opt in on this. And also the category, the last category is fairly significant. These are deleterious mutations or predicted deleterious mutations in genes that are not currently associated with disease. So these are the new gene discoveries where we might contact you later and say, oh, now this gene has a clinical relationship, and so we may point that out in an amended report. All right. Can you tell me what time it is? No, I don't. Okay, must have started early. All right, so I'm going to now talk to you about our clinical program. So we started offering exomes in 2011 at ASHG. So far we've gotten about 1,500 samples, and you can see here that it started out fairly slowly. We had a big jump for some reason around September 2012, and now it's been fairly steady at about 170, 180 samples per month. So far we've gotten about 1,500 to 1,700 samples. Most of them are pediatrics. About 85% are from pediatric age patients, but about 15% are from adult patients. They're by far and away neurologic, so intellectual disability, neurologic findings such as epilepsy or movement disorders, and then neurologic as well as other organ systems, so developmental delay and multiple congenital anomalies. But we have had some examples of other types of disorders, skeletal dysplasias. We had a couple of cases of pulmonary artery hypertension, some with cardiovascular disease. And they come from a variety of referral sources, mainly academic medical centers. In the beginning, I'd say that we received samples mainly from those real diagnostic dilemma patients who had been on diagnostic odysseys for many years. And so clinicians had a group of patients that they wanted a different approach to, and we would receive those patients. Now I would say that there's different clinicians are using it in different ways. Some are waiting for a complete workup and then ordering it. Others are ordering it fairly early in the diagnostic process. And I think we're still learning when the best time to think about ordering this test is. Looking at it separated by referral source, 61% are from genetics referral sources, 24% from other pediatric subspecialties, 12% from neurology. So I'm going to talk now about the first 1,000 cases that we've issued final reports on. It's actually 1,012. We have solved or probably solved 26% of cases. And so when I say probably solved, I mean that this might be a variant of unknown significance that had not been reported previously, but we have multiple layers of evidence to say that this is most likely the diagnosis, either based on inheritance pattern or being de novo, or perhaps the type of change in symptom polyphen. 149 of these were autosomal dominant. Of those, 91 were de novo mutations. 29 were inherited from a parent, either symptomatic or perhaps with some decreased expression. 29 of them we had no parental data. 81 were autosomal recessive. For the ones that we had parental samples, most of them or all of them were inherited in trans. 27 were X-linked, and then interestingly, 8 patients had 2 diagnoses, and I'll talk about this a little bit more in detail as well. So these are either 2 diagnoses that are completely separate, or 2 diagnoses that actually were blended to perhaps make a phenotype that was a little bit harder to recognize. We've had in these first 1,000 reported cases some recurrent diagnoses. Probably the highest one with 19 patients are mutations in the chromatin remodeling complex, so SWI, SNF. This is ARID1A and ARID1B, and others. We've had 6 patients with mutations in the Noonan spectrum disorder, so a variety of different genes. 5 patients with mutations in SYNGAP1, 4 patients with mutations in the Cornelia-de Lange spectrum genes, and again, a variety of genes within that phenotypic spectrum. This is just a slide, a relatively old slide from when we had looked at our first 250 cases. Our positive diagnostic rate at that time was 25%. Now it's a little bit higher, 26%. But I think this is the figure that this is going to be the figure until we come up with maybe some better ways or our interpretation is slightly more informed with other techniques. Just to point out a couple of different genes here from the autosomal dominant, P10, PTPN11, the Noonan spectrum genes, the CAT6B, which was that genitopatellar gene that I mentioned previously, ARID1B and ARID1A. These are autosomal recessive. There are a couple of metabolic conditions in here, and then here's some of our X-links. Some of these are quite rare, like the CASP gene. Others are fairly common, MECP2. The MECP2 was one of our early positive findings, and that was in a male. Cases with 2 molecular diagnoses, I think that we often think about wanting to make one diagnosis as a unifying diagnosis for our patients, but I think from our experience with Exome, we're seeing that patients can have a blended phenotype. Some of the examples here are ones in which they would be fairly similar and perhaps again would make a blended phenotype. So this mid-face retraction syndrome at the top here and myotonia congenita. Underneath is 2 syndromes that would be really completely different. So Aicardi Gutierrez in a patient who also had X-linked hypophosphatemic rickets. I'll talk about this third one, the congenital myasthenia, and the cardiomyopathy in detail a bit later. This case was interesting as well. This is a Carpenter syndrome patient who also had a mosaic NF1, and this patient had cafe au lait spots. This is a list of some patients, some diagnoses that we felt had an immediate impact on medical management. There are many more examples in this, but just on this table here are a couple of interesting ones. We have had 3 cases of congenital myasthenia, and so these are conditions that can be treated with the acetylcholinesterase agents. We had one case with a biotin or thiamine-responsive encephalopathy. Unfortunately, this patient was in his teens at the time this diagnosis was made, so probably too late to have an impact on clinical presentation or outcome. This is an interesting patient. The second one is an interesting patient as well. This is a patient with central hypoventilation syndrome. In the clinical note, it was the diagnosis was actually pulmonary hypertension. This patient also had Hirschsprung's disease, and so this FOX2B gene is associated with a central hypoventilation syndrome that can have Hirschsprung's disease, and so this was an interesting finding. This one as well, the trichohepatoenteric syndrome, this is a very rare condition. I was reading somewhere about that it's about 1 in 500,000 patients. So this is a presentation of severe diarrhea in infancy. The patient had that phenotype. And I think that this was important for the management of this patient because if you read about these patients, they typically are on parenteral nutrition, often until they're in their teens, which they then can be weaned off. And so I think that there would be some important information for families that this might be a very long-term issue, that they have to be on TPN, but eventually the outcome, at least from that perspective, can be improved. Trying to weed out who is more likely to have a positive diagnosis, we separated the patients into a couple of different categories and then looked at our positive rate. So if you look at neurologic, so this would be developmental delay, speech delay, autism, a very broad category. You contrast that with neurologic plus another organ system. So this would be perhaps developmental delay as well as multiple congenital anomalies versus a specific neurologic finding such as a seizure disorder or a movement disorder, and then non-neurologic. The highest pickup rate was for a specific neurologic finding, followed by neurologic alone. I think we're still kind of teasing this out to figure out what are the indications in which you're more likely to have a hit from this approach. One of the interesting findings as well, if you've ordered the exome sequencing test and let's say you don't have a definitive diagnosis, but that we've listed a number of autosomal recessive conditions where we found one hit, but we didn't find a second hit. What do you do after that? So many times people are doing Sanger sequencing for the entire gene. If it sounds like a very promising fit with the clinical phenotype, we would offer Sanger sequencing for that gene. But then you also have to look at copy number. And so this is a case where there was a mutation found in an IL-7 receptor gene. And so we then took a look at the array, and it was found that the patient also had a deletion in that same gene. So this is an example where you can utilize 2 different diagnostic modalities, or that you need 2 different diagnostic modalities in order to confirm the diagnosis. So positive array finding with a single exon deletion as well as a point mutation by whole exome sequencing. And this is a very severe SCIDS case. Medically actionable, so this is of course an area of great interest currently. So if you look at the first 1,000 patients that we've reported 77 in the category of medically actionable, so that's 7.6%. not extremely high, but I think for each of those patients, there is a number of steps that then have to be undertaken in order to look for that medically actionable finding in the proband as well as in the family. So if you further tease that out, 62 of the 77 had mutations in genes that are currently on the ACMG incidental finding list. So as you recall, we have a different threshold. So we had approximately 15 patients that we reported on top of the ACMG incidental finding list. 65 of the 1,000 patients were reported as carriers for mutations in the ACMG or the ACOG carrier genes. These are some examples of the medically actionable mutations that we've reported, some fibrillin mutations as well as some hereditary cancer genes. We also chose to report G6PD because there are some measures that can be taken in these patients to prevent symptoms. Most of the other patients carry mutations in cardiovascular disease genes. And then in terms of our new gene list, as I said, this is an area where we keep and we update our file of new disease discoveries. We go back to the exome results, and if we've had a hit in one of those genes, we would issue an amended report. So 13% of the positive cases from this first 1,000 carry mutations in disease genes that have been discovered since January of 2012. So I think this is showing you that this is a very active area, both in research and then in translating these findings to the clinical setting. And this may be one of the fastest ways of incorporating that kind of new information to clinical diagnostics. What are the different scenarios that we are receiving samples? Again, pediatric mainly, some adult patients. We also have done some prenatals, not ongoing prenatals, but pregnancies that have resulted in fetal demise. We found a DOX7 mutation in a case of fetal akinesia, also a Cornelia de Lange mutation in a case of multiple congenital anomalies. We've also done a case of where there was a consanguineous family with 2 previous affected children without a diagnosis of lactic acidemia, but without a specific diagnosis. And so we did exome on both parents looking for genes in which they both had a hit because of the consanguinity. The hypothesis was this was recessive. And so you can see that there are a number of different settings in which this could be a potential approach. Often there is some concern about the size of the report, how many variants you'll have to deal with. So we put together some overall statistics about how many variants or mutations fall into these different categories. So on the focus report, this is the range that you'd have to deal with for disease causing, so these would be diagnostic 0 to 2, related BOSs about 4 to 9, medically actionable 0 to 1, and so on. So a fairly manageable number. If you order the expanded report, though, and this is ordered by about 1/3 of the physicians as a second-tier report, the number gets a lot higher. Most cases have had extensive prior evaluation. We're trying to figure out a good way to do cost analysis, but of course this is a much more broad study that will have to be undertaken. But if you look at the clinic note, most cases have had an extensive prior workup that includes array, metabolic, single gene tests, et cetera. And this is just an example of one patient who had 3 different rounds of testing prior to the exome. Can you give me the time? Okay. So I'm just going to go through a couple of cases, and then I've got a short video that we're going to try to put on. So the first case is a 9.5-year-old Caucasian male. He had several episodes of weakness, spells of apnea that resulted in him needing intubation, increased respiratory secretions, ptosis, dysphagia, and usually when suffering from a febrile illness. At 8 months of age, he was also diagnosed with the cardiomyopathy, but apparently it said it had not recurred or at least not progressed. family history was very significant for a younger sister who died when she was 20 months of age. She developed a febrile illness, stopped breathing, and could not be resuscitated in a hospital setting. There were other siblings in this pedigree who were unaffected. This patient had multiple workup. Also, physical exam really was not contributory, although there was ptosis that was noted. He had a muscle biopsy. He had multiple single gene testing. He had metabolic testing, all of which was negative. So on the exome, a mutation was, or two mutations actually, because this is autosomal recessive, was found in the rapsin gene. This causes congenital myasthenic syndrome. The symptoms are quite consistent with what this patient had been experiencing. And then, of course, there is treatment available for this. For outcome, once the diagnosis was made, prophylactic treatment was initiated, and the physician said that his condition had been, he hadn't had another episode. This was complicated probably by this finding. So the patient also had a mutation in a cardiomyopathy gene, and so this may have confused the clinical picture because of the cardiomyopathy on top of the congenital myasthenia. This second case is courtesy of one of our genetic counselors. This is a 38-month-old patient with static encephalopathy, hypotonia, and seizures. She was on Keppra for seizures, non-dysmorphic, nothing really contributory from the physical exam. She had been evaluated in genetics and neurology for hypotonia and motor delays. This is her picture. She had also undergone an extensive workup. There was a CMA finding, but this was paternally inherited and not thought to be contributory. So exome was ordered on this patient. She had a mutation in the GLUT1 gene. So this is glucose transporter 1 deficiency, characterized by infantile onset seizures, movement disorder, inherited autosomal dominantly, and a ketogenic diet is effective in controlling the movement disorder and seizures in these patients. So the family was brought in. I believe both parents were negative here. The patient was referred to epilepsy clinic to start the ketogenic diet, and after 3 months she had been taken off Keppra, had no further seizures, and the family was reporting some improvements and that she was more active and alert and that her balance had improved. This third case, 15-month-old with failure to thrive, hypotonia, and global developmental delay, actually did not have a finding that was related to the phenotype. So this is a look at our report. So all of these findings here, some of them were recessive. Again, if the clinician thought that any of these was a good fit, you might want to do Sanger sequencing to confirm that there were no other findings, or you might want to do an array. But unfortunately, if you look at table 3, a finding in a medically actionable gene was discovered in this family. So we didn't have a diagnosis for the clinical phenotype, but there was a medically actionable finding, and this was in the Brugada gene. So Brugada syndrome, as we know, is characterized by conduction abnormalities, can result in sudden death. There is surveillance that is recommended, so ECG every 1 to 2 years. Symptomatic patients can be managed with quinidine, and there's some agents that they should avoid as well. So when this family was called in, there was some history of sudden death in a paternal first cousin and a paternal great uncle. This mutation was inherited from a father, and so both the proband and the father were referred to cardiology. So there's obviously a lot that the family has to deal with. First of all, we didn't have a diagnosis for the main indication for testing, but then something unexpected was found. Many different types of feelings that the family encounters, but they did seek to have screening for both the proband and the father. This last case is actually from a clinician, and I think that I'm going to skip this and go to our video. So we So when we have these cases that we're signing out, there are often, a lot of other individuals that we have to call in for opinions. So other clinicians, other geneticists, neurologists that we like to seek their opinion as we're reporting out cases to determine whether our findings truly are significant. So we have an Exome sign-out conference that I just wanted to show you a snippet of. Great, just a minute or two. So there's a little introduction. So welcome everybody here today. We're having another of our Exome sign-out meetings, and we're videotaping this meeting again for distribution on our website. The format of these meetings is for us to present some interesting cases. Today the presentations are going to be from lab directors from the whole genome and laboratory and the MGL. And we have in the audience some clinical faculty from the Department of Molecular and Human Genetics, also other faculty members from other departments. So with that said, I'd like to call Megan up for the first case.
Okay, so the first case that I'm going to talk about is one that we kind of see quite a bit in the lab. It's a 4.5-year-old male child presented with severe intellectual disability, profound hypotonia, spasms, dysmorphic features, failure to thrive. Structural brain abnormalities, if I remember right, it's just kind of a gross loss of brain matter, I believe. And so what we kind of put on the short list of genes for this patient is a number of autosomal dominant changes and some autosomal recessive changes. And so this whole group right here were autosomal dominant genes that we detected variants in, but they were all detected in a parent, and things that we see quite often in intellectual disability and patients with seizures. So ARID1B, ARID1A, SHANK3, all of these genes had a change detected in the patient, but they all were detected in a parent. So most of those genes were discounted.
Were they one parent or the other parent?
Probably. I mean,
it's the first time they come together in the baby.
All of these changes?
No, I'm just saying, if you have two of those from one parent, three of them from the other parent, the fact is they're unaffected parents, but for the first time you have a load of 5.
Right. Now, that would probably, I would take into consideration more if we hadn't had detected a de novo variant that wasn't in either parent's in the GRIN2B gene. So this kind of gives you an idea of what we deal with before and after Sanger sequencing, right? So all of the autosomal dominant genes that we looked at were all potential candidates in one combination or another, but only after the Sanger sequencing, when we go back and re-review, I can essentially discount most of those because they came up in a parent, but we do have a de novo change in this particular gene.
So this just gives you an example of our Exome sign-out conference. We, as you heard Jim Levsky give some comments there, often Art Bodette or Richard Gibbs will be there, and so some of the discussion is fairly lively. We've put up 2 of these sign-out conferences on our website. I think there's a third one that's probably going to be up next week. So if you have time and you're interested in taking a look at some of the cases and some of the process, I invite you to take a look at that. If you could just put up my last acknowledgement slide. There's a whole very large team of individuals at Baylor, and just wanted to give them a little recognition. Thank you very much for your attention.